Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, in recognition of Skin Cancer Awareness Month, it's a conversation about melanoma with Dr. Harriet Kluger. Dr. Kluger is the Harvey and Kate Cushing Professor of Medicine and of Dermatology at the Yale School of Medicine. Here's Dr. Weiner.
Now that it's early May, we've left those cool, rainy April days behind us, and that means the sun is out more and there are warmer temperatures. That's all very nice, but it's also important when the sun is strong for people to take protection against the sun and from UV rays. And that brings us to the topic of this evening's conversation, which is skin cancer and melanoma. If anybody wants to take a guess about the most common type of cancer, you can, but I'll go ahead and give you the answer, which is that it's skin cancer. Tonight, I'm joined by Dr. Harriet Kluger, who's the Harvey and Kate Cushing Professor of Medicine and of Dermatology at Yale School of Medicine, the director of the Yale Specialized Program of Research Excellence in Skin Cancer, and chief of the Division of Skin and Kidney Cancer at Yale Cancer Center. Harriet, maybe you could first start off by telling us a little bit about melanoma and what is it?
So melanoma is a tumor that arises in the pigmented cells in our skin. It's the cells that give our skin its color. Sometimes they're exposed to radiation, as you just mentioned, particularly when we go out in the sun and we get sunburns. And that causes those cells sometimes to mutate. In other words, they undergo changes that can then render them able to grow freely in an uncontrolled fashion. And that's what causes cancer.
Who's at the greatest risk of developing melanoma?
So in general, sun-exposed melanoma is much more prevalent among individuals with fair skin, red hair, blue eyes. Those are the folks whose cells don't make a lot of pigment. So they do have the cells there, but the pigment which is supposed to protect us from those UV rays coming in and causing the mutations, those layers are thin in people who have fair skin.
I actually never understood that. And how big a risk factor is it? So if you take somebody with fair skin, and I realize that there are gradations of fairness, but you compare somebody who's very fair versus somebody who has more of a Mediterranean complexion and may be somewhat darker. What's the relative risk there?
So I don't know that there's a number to that because there's so many behavioral components that go into this. But what we know is that the incidence of skin or sun-exposed melanoma is by far the highest in Australia. So you have a few million Irish emigres going to a country that's near the equator with a lot of sun exposure, and that's why the risk is so high. In Ireland, the risk is substantially lower than in Australia, so it's an environmental thing. But I would say also that we do see melanoma also in individuals with darker skin. You see it in Italy and Spain and all of those countries as well. It's just less prevalent.
And what about individuals who are Black or African American? My understanding is that it's uncommon, but they too can get melanoma.
So they tend to get melanoma on the palms and the soles and under the nail beds. We call that acrolentigenous melanoma. So those are not associated with sun exposure, but they are more prevalent in African Americans. And then mucosal melanoma, so melanoma of the mucosal areas of the mouth, the anus, the nose, those can affect anybody. And those also are not sun exposure related.
Not related to sun at all.
No, not related to sun at all.
And in general, treated in a similar way to other melanomas?
We try. They're less sensitive to the immunotherapies that we're going to be talking about, but they still are sometimes sensitive.
So maybe you could tell us how common melanoma is.
So primary melanoma, which means melanomas that arise in the skin, are actually very common. It's over 100,000 cases a year in the United States. Fortunately, most of those are caught early and taken out, and then they don't bother us again. At least 80% you don't hear from again. It's the ones that are thicker. If they've been there for longer and have gone to lymph nodes, those are the ones that pose a greater risk of spreading, and those are the ones that we worry about and we need to treat. And that's approximately 10,000 cases of metastatic melanoma a year in this country.
And before we drill down on melanoma and talk about both surgery and medical treatments and a whole range of new therapies that have become available, can you just touch on other skin cancers which do make skin cancer the most common cancer? Skin cancer is very, very common.
Yes.
And most of it is entirely non-life-threatening.
That's correct. So squamous cell carcinoma of the skin and basal cell carcinomas of the skin are by far more common than melanomas. They tend to be amenable to simple resection. Every so often they do spread and become a problem. And then the other one that is actually quite rare but becoming more common is Merkel cell carcinoma, which wasn't even an entity until the 1980s when it was first described. And we're just seeing more and more cases of that. And that one is very aggressive and tends to spread.
And what kind of cell does that start in?
Oh, that's the million-dollar question. We actually don't know what a Merkel cell really is. It's some form of neuroendocrine cell, which means that in our embryonic life, it comes from the neural cells of our body. But we don't actually know what the cell of origin is in the skin.
And for the most part, people who have basal cells and squamous see a dermatologist. The dermatologist removes it and they're done. Is that accurate?
Largely, yes. And every so often they need to see a plastic surgeon if the lesion is too big or if it's invading adjacent structures.
But treatments like chemotherapy and other kinds of treatments, immunotherapy, for example, are not used other than in very rare cases.
They're fairly rare, but yeah, they actually are being used more and more often, and they work very well in those diseases too.
And isn't this one of these things, if you're a skin cancer doctor at a cancer center, you're going to see more of these cases. But if you're out in a community dermatology practice, what you mostly see is the ones that are pretty easy to treat.
That's correct.
Let's talk about melanoma. And maybe first, and I recognize you're not a surgeon, but one of the things that happens when you work in a multidisciplinary program is, as a medical oncologist, which you are, you become surprisingly knowledgeable about all the surgical issues as well. And what's the role of surgery in melanoma?
So if somebody has a stage 1 melanoma, which is a melanoma that's confined to the skin and not very deep, almost always the only treatment that's needed is surgery. If it's a stage 2, which means it's invaded deeper but not gone to the lymph nodes as far as we can tell, there too, almost always they start with surgery. We rarely will give additional therapy, only when it's really, really thick. Or if it's very big. So sometimes the melanomas aren't just this tiny little dot in the skin. They can spread and become big. And if they're in a location that may be difficult for surgery, like the tip of the nose or the sole of the foot, places like that are that surgery can be damaging, we might give immunotherapy first or even immunotherapy only.
And let me just ask, and how do you know if cancer has spread to the lymph nodes?
So the first thing that we do is a biopsy. The dermatologists usually do the biopsy. So we know the depth, and we've got a pretty good sense of how aggressive it is because there are various other features beyond depth that the pathologist can look at. If it's deep, if it's got various other aggressive features like ulcerating through the surface of the skin or invading the nerve structures, then we will do various forms of scans to see if the lymph nodes are involved. And of course, we examine people. Sometimes you can feel it on physical exam.
And is there still a role for sentinel node biopsies in the management of patients with melanoma?
That's a big topic. I think we'll have to have an entire discussion on that because it's a moving target, and we could have a wonderful multidisciplinary discussion about the role of the sentinel node with our surgeons.
So I take it the role is fading because it used to be fairly prominent.
It's less prominent.
Yeah. Okay. All right. So you have seen in your career, and your career, it does not span 50 years or 40 years or even 30 years, but in a shorter period of time, you have seen dramatic advances in the treatment of melanoma. This was a cancer that when it spread, and, as you said earlier, many cases are cured with surgery alone, but when it would spread in those 10,000 people a year, our treatments were really limited. Chemotherapy didn't really work. And what has happened is really remarkable. So tell us a little bit about that and the role that immunotherapy has played.
Well, that's my favorite question, Dr. Weiner. So when I started seeing melanoma patients in approximately 2001, if somebody's melanoma had spread to internal organs, we would say, we're really sorry. You've got somewhere between 6 and 12 months to live. Get your affairs in order. We promise to do our best. Now, even then, we had a drug called high-dose interleukin-2 that we could sometimes give to people who were really robust, and approximately 5 or 6% of the time it would actually cure a patient. So it wasn't that 100% of our patients didn't make it. But we really tried until that period of like the early 2000s. Study after study was negative with various different variations on the interleukin-2, combining interleukin-2 with chemotherapy, etc. And then in around...
And can I just stop you for 1 second? What did interleukin-2 do? Did it in some way stimulate the immune system, given what we know now and what you're going to get to?
Yes, it does. But so interleukin-2 is a substance that our body makes when we have, say, a virus. And the idea was if you give it at massive doses, maybe we can stimulate the immune cells in the body. I think the knowledge of immunology at the time was much simpler. And what actually happened was with high doses of interleukin-2 is that you're stimulating the good T cells. T cells are the main soldier here against the cancer, as well as the bad T cells. So you've got good soldiers and bad soldiers, and the interleukin-2 will stimulate them both. And we've gotten much more sophisticated with that since.
In about a minute, we're going to have to take a break. So let me just break this question about immunotherapy into some smaller bites. Can you tell us about the very first studies with immunotherapy that you were involved in and what you saw in those early days before we knew this was standard?
So the first drug that we had was a drug called ipilimumab. I didn't make the name up. We saw that it would induce these really beautiful, durable responses in approximately 10 to 15% of our patients. So not very many, but it was a one-and-done kind of treatment. You treated until they had toxicity, and then they would go on and live their lives. That was the first one. The second one was a drug called nivolumab. The trial here was led by Dr. Mario Schnoll, my colleague. And there we saw the responses in a higher percentage and less side effects. But there too, the responses were phenomenal. So we then combined the two together. This was Dr. Schnoll's idea, and that really changed the world of oncology as we know it.
Well, we're going to talk more about this in just a minute. We're going to take a quick 1-minute break now. I'll ask our audience to stay tuned until after the break, and we'll talk there extensively about immunotherapy and how it has totally shifted the care of patients with melanoma over this past decade and a half. We'll be right back.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where researchers, as part of the Yale SPORE in skin cancer, work to improve prevention and therapies for patients with melanoma. SmilowCancerHospital.org. It's estimated that over 240,000 men in the U.S. will be diagnosed with prostate cancer this year, with over 3,000 new cases being identified here in Connecticut. 1 in 8 American men will develop prostate cancer in the course of his lifetime. Major advances in the detection and treatment of prostate cancer have dramatically decreased the number of men who die from the disease. Screening can be performed quickly and easily in a physician's office using 2 simple tests, a physical exam and a blood test. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and its Milo Cancer Hospital, where doctors are also using the Artemis machine, which enables targeted biopsies to be performed. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again. Welcome back to Yale Cancer Answers on this Sunday, May 4th. I'm Eric Weiner, and I'm joined tonight by Dr. Harriet Kluger. For those of you who are just tuning in, we've been discussing skin cancer and mostly melanoma, which is a form of skin cancer. We talked a little bit about preventing it by avoiding sun exposure, given the fact that sun is such a risk factor for melanoma. And we're continuing to talk about some of the treatment for melanoma. I will remind everyone that May is actually Skin Cancer Awareness Month, so it's not entirely by accident that we have this program tonight. So, Harriet, we were talking about treatment, and we were specifically talking about immunotherapy and what I would call the immunotherapy revolution in metastatic melanoma. So this was a disease that, with a few exceptions, took virtually everyone's life 2 decades ago. What's happened?
So in the last decade or so, we've had approval of multiple regimens. The first one was that drug called ipilimumab that I mentioned earlier that worked around 15% of the time. The second one was a class of drugs called PD-1 inhibitors. There are 2 in that class, nivolumab and pembrolizumab, and those are going to work around 30% of the time in the front line. And when you combine the 2, you see more side effects, but over 50% of our patients are now responding. And when I say responding, they tend to respond for a long time. The 10-year survival from the seminal trial was just published, and approximately half of the patients are alive 10 years later. Some required some retreatment, but a lot of them required no further therapy.
Wow. I mean, that's a pretty big difference compared to what would have been 3 to 5% 20 years ago at best.
That's correct.
And tell us a little bit about the lives that these people are living who are surviving to 10 years.
So the vast majority of patients have no long-term side effects. Approximately 15% have pituitary dysfunction. So we have this gland at the base of our brains called the pituitary gland, and it controls our hormonal functions in our bodies. And if that gets inflamed, it's not reversible. Less than 1% has diabetes. There are very few percentages here and there that have long-term side effect, but most of the people just live their lives after that.
And, on some level, I think the side effects of immunotherapy are both very challenging. They're also a little bit fascinating because, of course, it's essentially unleashing the body's immune system on itself. So can you talk a little bit about that and how these checkpoint inhibitors work?
Yes. So we all have these immune cells in our body called T cells. We manufacture them in our embryonic lives. And those T cells remain in our different organs, and they may recognize our normal cells. In other words, they're prone or they're able to fight against our normal cells, but they're kept quiescent. And when we give these immune checkpoint inhibitors, be it ipilimumab, nivolumab, pembrolizumab, or there's a new one on the block also called relatlimab that I need to mention, that works in a slightly different mechanism. When we use these, we activate all the T cells, not just the T cells that recognize the tumor cells as bad. So that's why we get inflammation. It's almost like autoimmune diseases. So Crohn's disease, rheumatoid arthritis, those kinds of diseases are long-term autoimmune diseases. With these drugs, we can cause autoimmunity, Most of the time it's short-lived, so we don't call it a disease, but it's not always reversible.
But essentially, these drugs are allowing a person's own immune system to fight and attack the cancer. Is that
Correct?
pretty much accurate?
That is very accurate. And the side effect is that sometimes it attacks normal cells as well.
Yeah. And I know the area of side effects with immunotherapy is under active research. Any thoughts about predictors for who gets side effects and who doesn't?
So a lot of studies have been done on that, and we're still refining them because they're challenging to do. You've got to collect the tumors and blood samples before patients go on therapy. Then you don't know who's going to get the side effects. So to operationalize these kinds of studies is quite challenging, but studies have been done. There's certain kinds of B cells that exist before a patient goes on therapy that'll render them more likely to develop side effects. There's certain subtypes of T cells as well. So various immune cells that we can actually identify beforehand. The problem is that you've got a patient with metastatic cancer, so you're going to give the drug anyway. The question is whether you can predict which side effects that you're going to get, and then those that you know are going to get the worst of the worst, you'll withhold therapy for them. But we've got a lot of studies going on here at Yale as well in that realm.
So let's move on and talk about a new type of therapy, and that's what's often referred to as TIL therapy. TIL stands for tumor infiltrating lymphocytes. Maybe you could just tell us a little bit about some of the background here and maybe the first step in the whole process of doing TIL therapy, and then we'll move on from there.
The background is as follows. In around the early 2000s, Dr. Stephen Rosenberg at the National Cancer Institute developed this therapy. He would take patients that were referred to him from all over the United States. And so there were very few patients who were actually able to get there for the therapy, but they saw a good response rate. And the TIL therapy was being developed concurrently with the immune checkpoint inhibitors that we just discussed. So for most places outside of the National Cancer Institute, it made most sense to give the immune checkpoint inhibitors first. We now have TIL therapy that we can give at any site, actually, and we'll go through the process in a minute, but it's now given as a second-line therapy. So either patients whose tumors don't respond to the other type of immunotherapy or who can't get it because they have underlying autoimmune disorders.
Got it. And how do you begin to think about TIL therapy in terms of what are the first steps as you're getting a patient ready for this?
So the first step is to identify one tumor that can be removed. So the idea is that the T cells that live inside the tumor are just exhausted, but they recognize the tumor. They're activated against the tumor cells. So you have to take a tumor out, and then you need something else that you can follow to make sure the patient's responding. So they go to our surgeons and they remove the tumor, and it gets sent to a central lab.
And do all tumors have these tumor infiltrating lymphocytes? Can you find them if you remove a tumor reliably?
Approximately 80% of the time we're able to grow these tumor infiltrating lymphocytes. Not always, that is correct.
So this is highly individualized. You're taking a person's own lymphocytes and you're then growing them or expanding them?
So that's correct. So you take the cell out, then in a lab, the tumor cells get separated from each other, and you sort out the tumor cells from the immune cells. Then you grow the immune cells in a petri dish with all sorts of growth factors, like the interleukin-2 that we talked about earlier, and a few other factors, and we expand them to the tune of billions of cells. And then we bring the patient back in. We give them high doses of chemotherapy as an inpatient. We infuse their cells back, and then we give them some more growth stimulation with interleukin-2.
And how long does this whole process take? I mean, from the time you do the biopsy until you're ready to infuse these cells back, what's the time period?
It's approximately 7 weeks until the infusion is normally 3 or 4 weeks after the surgery, and then it takes another 3 weeks or so to recover. So the entire process takes around 7 weeks from start to finish.
And this growing of the lymphocytes, does that happen at every individual place where a patient's getting care, or are they sent to some central laboratory?
So right now we're sending them to a central laboratory. We actually do have a lab at Yale Cancer Center, which is run by Dr. Diane Krause. A few years ago, we did do the cell growth in our own lab, but the FDA-approved product that the insurance companies pay for is now being grown in a central lab.
So this is now a new treatment. I won't call it a drug because it isn't quite a drug, but it's a new treatment that even for patients who have received immunotherapy and for whatever reasons haven't responded, it's yet another option.
That is correct. It's yet another option. And I also want to say that I believe we're working on version 1.0. We're going to get much more sophisticated at engineering these cells and activating them even further.
And that brings me to my next question, which is about clinical trials. So none of these treatments go from a laboratory into a patient's vein, or in the case of oral therapies, not that we've talked about many oral therapies, into a patient's mouth without a big clinical trial process. And what's involved there?
There's a lot involved there. So the therapies that we talked about earlier, we actually did the phase 1, phase 2, and phase 3 trials here at Yale. So phase 1 is first in human. You look at the side effects and you determine what dose is the best one to use going forward. Phase 2 is a bigger trial where you compare to a historical control. And phase 3 is a much larger trial with hundreds of patients. Every patient that goes on a clinical trial involves many, many people doing data management, research nursing, answering the phone for unexpected side effects, reporting to the FDA. There's a huge apparatus that exists around clinical trials. But if we don't do them, we will still be using version 1.0 in 15 years. But I'd really love you to interview me on Yale Cancer Center Answers in about 5 years' time, and we can talk about version 2.0 of TIL therapy.
No, it's really important. And I think that for our listeners, I think one can't possibly overstate the importance of clinical trials in moving the field forward. The reason that we have new therapy and the reason we have better therapy, better treatments, and longer survival times in many, many patients with cancer is because of clinical trials that, of course, arise because of oftentimes observations in laboratories.
I couldn't agree more. And I think sometimes there's a perception that going on a phase 1 or an early phase trial means that there's no hope, and that's the only reason to do it. And that might have been the case in the 1990s, but nowadays some of our best drugs are coming through phase 1 trials. The science is so much better, and it takes so many years from a first-in-human study until FDA approval that oftentimes phase 1 is the access to the best drugs early on.
Dr. Harriet Kluger is the Harvey and Kate Cushing Professor of Medicine and of Dermatology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.